Okay, so again, weeks 5 and 6 are going to be spent in the skeletal system. That's going to cover 4 chapters in your open stacks. It's going to cover chapters 6, 7, 8, and 9. And these next 2 slides are going to discuss what is expected of us to cover. So we're going to look a little bit at the functions of the skeletal system. We'll talk about that cellular and tissue level as well. So we'll look at the 3 types of bone cells. We'll look at and see what it's a connective tissue, you'll recall from last week. So we do have a matrix involved. We'll do a little bone classification, talk about some of the makeup of that bone tissue, whether it's spongy or compact. We'll look at bone growth and formation. The role of bone and calcium homeostasis, very minimal time spent on that. That we'll see again in the endocrine system as well as next semester. So I'll just touch on that one very, very briefly here later on. And then bone remodeling as well, especially again after some sort of not only like a fracture, but also any type of stress that may be placed on bone. So we'll talk a little bit about bone spurs. We'll talk about sesamoids a little bit as well. And then page 2, so it just keeps going all the way to letter O. Describe the different types of joints and how they work, and then apply movement terminology to joint functions. This I and J go together. We're going to do that at the end. That's good. Joints go with chapter 9. So that's going to come at the end. I just copied and pasted these right from WIDS. So the order isn't necessarily the order we go in. It's pretty close. This spot here, it gets a little wonky. So, but we do put those we do discuss both of those. And then we'll spend quite a bit of time today and certainly on Thursday going through K and L, which are the axial and appendicular skeleton, the bones of those two, and then the different landmarks. And then finally, we'll go through a little bit as well with skull development and the different types of vertebrae. Yep, keep trucking. Exactly. Yeah, and good. Yeah, Craig, you're not. Trust me, bud. You're not alone. In fact, you're probably in the majority. Craig, in case you guys didn't look in the chat, he's still working on 4, and that's totally okay. I don't want you to feel any kind of pressure. There's enough pressure just inherently within the information. So just manage your time as best as you can. That's the trickiest part of life in general. We know that, right? We all have jobs and families and now school. So again, that's why I'm really not a stickler for due dates, but I have them set in there just so you stick as closely with the flow as you can, and you can certainly refer back if you need to. So yeah, just yeah, keep forging ahead. You have, again, we're taking this one 2 weeks, taking it a little slower. Next unit will be a 2 weeker. So yeah, so there you go. And yeah, good. I appreciate it. Craig appreciates all of you too. Yep, you don't want to miss. So coming to these and listening to what we discuss is excellent. It's even though it is new and you're still back there. At the moment, you're here now, and that's what's important. Is that your minds and your bodies, your brains, your ears, your vision, everything is right here and now. So even if you're not on paper necessarily ready to start moving forward, the fact that you're here tonight is extremely important, and I encourage you to you guys to come every time we have new stuff, which is, again, next week won't be new stuff, but I'll be in here if you need anything. And certainly use that time. View next Tuesday and Thursday, even though we don't have new stuff, as far as jobs go or families go, as far as they know, you have class live next week from 6 to 9 and 6 to 8, Tuesday and Thursday. Whether that enables you to hide out somewhere and really focus, that's 5 hours. You can get a lot done in that amount of time. So even if it's going backwards and catching up. So students ask frequently each semester, what do you recommend for that? And really, I think staying, uh, coming and being present with what we're doing is extremely important. So try not to miss class, especially with if we're face to face, and really, just etch out a little bit every day from the past stuff while still trying to check in with whether it's the Padlets, whatever it might be. But just stay organized, and it's all connected. You're realizing that too. Just because we chunk this stuff out week to week and unit by unit, that's another reason why I'm not really hard and heavy with the due date stuff. Because again, sometimes, especially as we get going, and keep getting deeper and deeper, the overlap is so obvious and so evident that sometimes some students wait to take exams until later in the semester too. I mean, so really it's I'm not saying this is self-paced, but at this juncture through 4 weeks now into week 5, it can start to kind of be a self-paced experience for you. But again, as we get closer to Thanksgiving and then the end of the semester and the holidays, as well as I do, things get nuts even with COVID. I mean, who knows? It's going to be post-election. It's going to be back to, family outing, family Thanksgivings, Christmas shopping. Think your brain's decorating the house. All of that stuff starts being an extra distraction. So try to really stay within that week behind. If you're back in 2 weeks behind, that's when things get squirrely. And now that we have next week kind of off, you can really get caught up. So as we head into the next unit, hopefully you'll be right there, and for the most part pretty well caught up with things. So and again, caught up is kind of like counter, it goes against kind of what I just said, but you know what I mean. Caught up in your own schema, I guess, of whatever it is you feel, wherever it is you need to be. Okay. All right. So anyhow, that's the agenda for the next couple of weeks, and so I want to go through a few things with skeletal tissue. This goes through chapter 6 in the open stacks. So a couple of the functions of bone I think are pretty clear. We need skeletal system to keep us upright, to keep our tissues from being basically in a puddle on the ground. So that's the support aspect. And this word ligaments we've seen before. We talked about a little bit last week with tissues. You want to remember ligaments provide support, structural support for a bone and another bone where they connect. So we oftentimes would see a ligament at what we call a joint or articulation spot. Articulation is the fancy word for joint. It's basically where the proximal end, for instance, with an arm bone and another arm bone, where a distal and proximal ends of bones come together. That is where we're going to find ligaments that help provide some durability and some support. So that's where that comes in. Protection, certainly with the skull and the vertebral column and the thoracic cage, we're going to be protecting quite a few of our vital organs. Movement, we have the next unit, we go through the muscular system, primarily musculoskeletal aspects. So we're going to be looking at the function and role of bone in movement, in being attachment sites for these skeletal muscles to enable movement to occur. And that's where we would see the term tendons. So remember, tendons connect a muscle to a bone. Okay, so ligaments are bone to bone, tendons are muscle to bone. So you could put tendons in there with the movement spot maybe. The next one, mineral storage. I think, again, that magic mineral we've been hearing about since we were little kids. Calcium is a big deal, of course, when it comes to bone. Our bones are mineral storage units, primary reservoirs. We'll see that term from time to time. that simply means we're able to store something. And for bones, we can store calcium. We'll see phosphorus, magnesium, probably another one that from the dentist, right? Fluoride is another one that is a mineral that bone is going to store. So build strong bones. So anyway, and then that last one, hematopoiesis. Um, yeah, Achilles tendon. Yeah, if you think of the tendons, your Achilles tendon is the one, that attaches your calf muscle to your heel bone. And we're actually going to talk about the Achilles here in a few minutes, Lori, when we're going to talk about bone spurs and stress on bone. But yeah, absolutely. Tendons provide movement. Okay, so think of the Achilles tendon. It connects that big calf muscle group to the heel bone. And yeah, ligaments and ligaments are what get sprained. So when you sprain an ankle, or sprain your knee or sprain your elbow, it's a ligament that typically gets overstretched and therefore gets a little bit inflamed. When you strain something, you're straining a muscle. So with a T, it's a muscle strain versus a ligament sprain. So another kind of side note and more mud to keep that murky water murky. All right. So anyway, hematopoiesis. That's a new one for probably all of you or most of you regarding functions of bone. I think the other four are pretty evident. This last one, poiesis, is a suffix that we're going to see from time to time, really over the next couple semesters. Poiesis has to do with producing something. So the process of producing is in essence what poiesis means. It's kind of redundant, but just think of production of. And hemato, we know, has to do with blood. So hematopoiesis simply has to do with blood production. So we're going to see blood cell production occurring with the skeletal system. And again, one of the things we're going to see, and you may see between now and Thursday with the portfolio for this week, just like we saw last week, or if you haven't gotten there yet, you will see it from last week. But the Unit 4 and now 5 portfolios, and we'll see them each week, they have that interconnection table where you're going to see how is the integumentary system in essence linked with these other body systems. For instance, we saw the urinary system. How is urinary and integumentary linked? And so we'd think of hydration and water, fluid balance, maybe temperature balance as well to kind of go with fluid balance. So you're going to see the same type of chart or table with this portfolio regarding how the skeletal system affects other body systems or how they're intertwined or interlinked with one another. Um, I kind of, it's totally up to you. I would probably hang out here and absorb some of this, but you could get the same thing, same experience too by watching it because it is being recorded. So, in fact, this afternoon's session is in there as well. So that's the beauty too of this. That again, it kind of goes back to that self-paced aspect because I managing time is difficult, I know, for all of you. So I want to make it as convenient as I can by, again, I don't require attendance. I do require really that you check in through Blackboard and by doing Padlets and assignments, and maybe drop me an email from time to time if you have questions. But the recording of the videos and having those available really enables all of you to be able to kind of, I guess, fit this in however it's best. So, I mean, if like work, if you've got a shift at work that you can take to make a little extra money, but it's a Thursday at 6 o'clock, I mean, you've got bills to pay, right? So pay those bills and know that session is going to be recorded and will be in YouTube and in Blackboard. And that's the other thing I wanted to mention too. In YouTube, in my channel, there's a folder, a playlist for general A&P. There's a general A&P playlist. So if for whatever reason, sometimes the transition from YouTube into Blackboard can be a little bit weird because Blackboard sometimes is busy or YouTube's busy anyway. They don't mesh right away sometimes, but that doesn't mean the video isn't available. It may be ready and viewable in YouTube, but for whatever reason, it's taking a while to get it into Blackboard. So if you just go to YouTube, click subscribe to my channel. I sound like a YouTuber. Uh, Click the like button and subscribe. Leave a comment. Please, you can if you want. But I don't expect any of that. But maybe subscribe, or at least have it in your like list if you're in YouTube or what. I don't know how that works, but have it available that way, because you can watch them all any time of the day. So anyway, so yeah, if any of you show up and leave, or don't show up at all, or show up and stay, I don't keep track. I trust that you are doing what you need to do. Okay. So anyway, there's the skeleton. We'll be seeing plenty of, I don't know if that answered your question. It probably did, but maybe not. Yeah, you probably should get on Unit 4 then. But again, that's up to you. I also wanted to mention, from time to time, students will email or call, or if it's a face-to-face, they'll ask about whether they think I should drop whether I think they should drop the class, or whether. And this is just a segue from where some students' headspace gets. Um, so so I appreciate that. If any of you ever feel like your back's against the wall, or you need some advice regarding that level, please talk to me before you do anything administratively. Now, that doesn't mean that there's always a way to work it out. And sometimes, though, it does lead, the road still ends up leading to a withdrawal or something like that. And thankfully, Gateway allows students to withdraw from a class all the way up until basically the last maybe 3 weeks of the semester. So keep that in mind as well. I don't want to see any of you put all this effort into it and then something happens toward the end and it puts a big wrench in the works. So please don't fall out, don't disappear. If it's in your control, don't disappear. Keep me in the loop, and if something were to happen. So anyway, now when it comes to your financial aid, and I don't know anything about that. So, but I do know that we can work together. If you need a tutor, we can get that going. But so anyway, you've heard it all before for the most part. Just want to reinforce it and make you aware once again. So anyway, we're going to get through this, I promise. 5 types of bones. We can classify bones based on their shapes, and part of the reason we do this is certainly to make it a little bit easier to visualize and see specific bones when they're separate from other bones. We generally see the skeleton and bones as this, and it's not easy, but it's also not as difficult to identify bones on what we call articulated skeleton. So being able to see these bones apart from the skeleton is where this comes in. It's maybe a little easier to see what's going on that way. The other reason we look at these different types of bones is we do see some distinct differences internally. So the obvious aspects are what they're named for. Long bones are longer than they are wide. So generally we think of the appendages, the arms and legs, as being long bones. We think of the hand and finger bones as being long bones. The short bones are going to be just that. They're going to be a little shorter, maybe more cube-like or boxy. We generally think of the wrist bones and the ankle bones as being short bones. Flat bones are going to be just like it sounds, they're going to be flat. They're going to be relatively thin. So maybe thin bones. And the other thing about flat bones is oftentimes they're curved a little bit. So like the bones of the skull, a lot of the skull bones are flat bones, but they do have curvature to them. We'll see the sternum or the breastbone, the shoulder blades, the hip bones, those are all going to be flat bones. That doesn't mean they're flat like a piece of paper. It more means that they're pretty thin. And a lot of times we do see some curvature to them. Irregular, we don't see a lot of those as far as differences from bone to bone. We generally think of a vertebra as an irregular bone. And then lastly, so these are kind of jigsaw shape. They don't really fit into the first three categories. That's why they're irregular. And then sesamoid is a floating bone. We typically think of a floating bone as kind of meaning that it doesn't really articulate with another bone. In fact, oftentimes sesamoids are kind of embedded in some sort of ligamentous or even muscular or tendinous material. So the main sesamoids that actually have names are going to be the kneecaps or the patellae. So we can see an example of a long bone in the humerus, and then we've got a kind of a boxy uh, carpal bone or short bone, and then the irregular bone of the vertebra, and then the sternum as a flat bone, and then the kneecap or the patella as a sesamoid. And then we see this illustration here. Another type of sesamoid is a sesamoid that kind of grows in an area where stress is found. So we'd see maybe a sesamoid in the hands area, around the thumb joint, the first metacarpal joint. We may see sesamoids in the feet, but typically we'd see them maybe in between metacarpals, and you wouldn't even know they're there. They're very tiny. They're probably the size of a mini M&M or a Tic Tac. They could certainly get a little bigger than that, but that's about generally the size that we would see. And you wouldn't know you had one unless you got an X-ray of the hand for something else. So maybe you had a wrist injury or a broken metacarpal or something. So we're x-raying for that, and then we'd see, oh, there's a little extra kind of bony, kind of a tic tac or mini M&M shaped bone in there. It's just an extra little bony growth called a sesamoid that again is there to provide a little extra support. Now a bone spur is a little bit different. Sesamoids generally are kind of encased in tissue, whereas a bone spur is going to be a kind of a bony outcropping of existing bone, and they usually show up in response to stress being placed on the bone. So most of these bony landmarks, so as we later tonight and certainly on Thursday as we go through bones, specific bones, we're going to also look at what are called bony landmarks. And bony landmarks are these little bumps and grooves and ridges that we see on bone. And a lot of these bony landmarks are going to be sites of muscle attachment, tendon attachment. So we'll say muscle attachment. Okay, so a lot of muscle attachment sites on these different little bony processes or these little bony bumps or ridges. And so the body responds to stress from muscle that's pulling on bone by adding more bone. So stress on bone builds bone is a law that we'll look at just briefly next semester. Like I said, we don't do a lot of skeletal system physiology, but we will talk a little bit about that briefly next semester. But we do see stress on bone does build bone. So that's what leads to bone spurs typically. Now, under the foot, the heel area, the calcaneus, where the Achilles tendon kind of comes down off of the calf muscle in the back of the lower leg, it kind of inserts a little bit underneath the heel. And if when patients wear high heels or just improper footwear that creates a heel, what it does is it or has a heel and creates what we call kind of a plantar flexion action, where you're kind of up on your tiptoes a little bit. Cowboy boots do it. We see this in men and women. Heel spurs are not uh, strictly for one demographic or another. Typically, it's a body's response to footwear issues, and oftentimes it's a heel that's causing the problem. So the calf muscle is in a state of what we call isometric contraction, and what that calf muscle is doing is pulling up and putting a little bit of stress on the underside of that heel bone or calcaneus. And so the body's response to that extra stress is to put extra bone where that tendon comes in. Well, that makes sense. So build up a little bit extra of a base or a foundation because of all that stress. So we're seeing it more and more in other places in the body, where some of you have maybe heard of spondylosis or spondylitis, ankylosing spondylitis or spondylosis of the back. These little spines are growing spurs on them, and often in response to stress. Again, if there's extra bone, it's because there's stress on the bone. Unless they could have, we talked about a little bit earlier today, they could have some sort of a genetic or a hereditary disorder regarding something to do with growth hormone or with calcium homeostasis. They could have like a hyper bone production, so they have what we call like acromegaly or gigantism. We could have dwarfism or cretinism, where we don't have enough of a growth hormone, and so we see this trickle effect going on. So short of those, talking about a healthy individual, we do see stress on bone builds bone. And so again, with postural issues, with gait issues, with any type of repetitive use issues, or depending on what type of job people are doing day in, day out, that body position stuck in one spot, or strained or stressed in one direction, what that's doing is it's pulling on bone. And so what happens, your body will respond by putting some spurs down. Where does it pull that extra calcium from to get those spurs going? Well, oftentimes, and this is a problem with the cervical vertebrae and the lumbar vertebrae, is we see that bone gets leached from this area around in here, as well as the body. This is called the body of the vertebra. This is the kind of the anterior or the front of the vertebra. And then this hole is where the spinal cord passes through. And then in between, kind of going out this way, is going to be where nerves are. Well, if I'm putting spurs out here to accommodate for extra stress, I can leach some of the bone from neighboring areas of the same bone. So I can, the bodies of your vertebrae have a lot of good calcium. They're pretty dense as far as bone goes. There's a lot of spongy bone there. So we can pull calcium and other items from these areas to put extra support out there. Well, that's great, I suppose, for these muscles, but it's not so great for the density of those bodies of the vertebrae, and certainly the density of these little bridges right in here that we'll look at later on today or on Thursday. The vertebrae start kind of collapsing onto one another, and what it does is it decreases the diameter or the tunnel diameter that these spinal nerves come off of. So patients come in and they have shoulder pains, they have wrist pains, they have elbow pains, they have low back pains, knee pains, hip pains. low back, hip pains, knee pains, on down the line. And we address these issues here, but we're also addressing postural assessment. We're addressing gait. We're addressing footwear. We're addressing repetitive motion. We're thinking about some sort of bracing or splinting to get some of the stress off of the bone. So then we can start getting maybe some of the spurs to come down a little bit and get some bone density built back up in these areas. Now, again, there are other conditions, right? Like osteoporosis and, um, you know, some of the other ones I mentioned before that, sometimes there's just no stopping what's going on. And so we have to be extra aware of kind of what's going on. Now, osteoporosis is a potential, there is a hereditary link, certainly. With most disease and disorder, there is some hereditary or genetic link. That link may be as small as 5 to 15% of all patients who suffer from a certain disorder. We can say that with 15% probability is all that it was genetic. There may not be anything in that person's line that shows that they're susceptible to osteoporosis. So why all of a sudden do they have it? The only other option, if it's not genetic from familial genetics, then it's genetic from what we call epigenetics. And that's what we consider to be environmental genetics, or how your genetics mutate or how your chromosomes can mutate during during replication and ultimately cell division based on environmental influences or environmental factors. And that list is miles and miles and miles long, right? So how come some people can guzzle soda every day and they're fine, and others can have a little bit of soda here and there, but it's enough to cause a buffering system to show up in their small intestines, and they stop absorbing calcium, and next thing you know, their bone density plummets, and they get into kind of an autoimmune switch where they have a new set point, and now they have bone density loss of someone with osteoporosis. So my point is, there are so many factors to so many diseases and disorders, and you guys all know this, but it is important to know what's a normal and what is normal, right? But what is a typical, I should say, bone supposed to look like, and spurs is not typical. And so form fits function. We maybe touched on that ideology day one. We touch on it a lot in advance, but form fits function. As physicians and as healthcare providers, we are looking at form a lot, right? We're looking at diagnostic tools. We sometimes we don't have to do anything but look at the patient, and we can tell that there's something wrong. It could be a skin disorder, it could be something in their posture, it could be something in their face, but we know that something is definitely wrong, or something is amiss. So again, it's really comes down to trying to figure out, based on structures, what may be functionally amiss. So if I look at if I look at an x-ray, if someone comes in and they're having pains and aches and shooting, stabbing, burning sensations in their feet, and I see their shoes, and take an x-ray, and ooh, and oh, spur, we're seeing the form, the anatomy, and that anatomy is abnormal. It doesn't fit into this. So we know then there's something functionally amiss. And that oftentimes then it has to do with calcium transfer and osteoblast and osteoclast activity. And so the function is different in those areas, and the form is going to fit that dysfunction. So malformation fits dysfunction, no different than form fits function. So anyway, that's the long and short of it there. No, let's see. Dehydration, stress. Yeah, they're interconnected. Yeah, absolutely. Again, it's that total package. And yeah, I think that, Kidney stones, there are a ton of factors. Dehydration, number one by far, is a big contributing factor. And I'm not talking just a little bit of dehydration. I'm talking systemic dehydration, and that systemic dehydration can be the result of, and part and parcel with, stress in your body requiring more hydration during more stressful situations, right? If you're under a lot more stress, blood pressure is different, tissues are different, demands for hydration are different. There's a lot more friction internally when we're under stress. That includes the kidneys. And so hydration issues manifest when stress manifests. Okay, so consumption, while on top of those things, caffeine um, is a diuretic. It's a dehydrator naturally. Alcohol is a dehydrator naturally. So two dehydrators are oftentimes common consumption um, liquids or whatever. Consumables, right? Common consumables are oftentimes dehydrators. Uh, um, High sodium diets, the foods. So it is always something that manifests as much as a kidney stone. That is a volatile group of a lot of activities that lead to that happening. um, Almost always lifestyle related. Not enough sleep, not enough hydration, too much stress, too much caffeine, too much alcohol, too much sugar, too much sodium. Up, 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 up. All of those can become the perfect storm for calcium, for kidney stone, and calcium. And there are several types of kidney stones too. So that's another. We'll get to kidneys a little bit at the end of the semester, and we'd also spend quite a bit of time next semester on fluid balance, pH balance, electrolyte balance, and the kidneys, and certainly how they roll and how they should function normally, and what happens when they don't function normally. Kidney stones are one of the result, and there are a lot of different types of kidney stones, and these different types of kidney stones have different shapes that have different than makeup, the chemical makeup. Some have more calcium, some have more phosphates, some have a blend of several different items, sodium included. So some of them look really, they look like jacks. Remember that bounce the ball jack? Some of them look like a jack, not that big and not nice and silver and shiny, but that kind of spiky shape and form. um well, sorry, there you go, Stephanie. So yeah, our patients tell us a lot about themselves with their personal choices uh with their diagnosis. So, but yeah, I know it's stress, right? Stress is it, and it leads to the ripple effect, right, Mr. Ripples. So anyhow, yeah, and they're painful. I thankfully I've never had one, but I know plenty of folks who have, and it's that passage from the kidney through the ureter down into the bladder. That's level 10 pain, maybe higher if it goes higher than 10, right? So anyway, so yeah, Lori, no, kind of yes and no. It's all intertwined. It's another facet. Okay. Okay, the other thing too with bone, we will see today what's called compact bone versus spongy bone. All bones we're going to see, it doesn't matter if they're long, short, irregular, flat, sesamoid, they're all going to be covered in some sort of connective tissue sheath called a periosteum. And many of you, I'm sure, have heard of that at some point. And that periosteum is is very tough, is very taut. And just underneath the periosteum is going to be what we call compact bone. And compact bone is a bunch of concentric rings of matrix, of hardened matrix with some bone cells inside. So we'll take a look at compact bone in a little bit. All bones have some compact bone. Spongy bone is going to be found in all bones as well, but we're going to see greater amount that basically the whole inside, the deepest parts of of short, flat, irregular sesamoid. So not long, short, flat, irregular sesamoid. All of those are going to be filled with spongy bone. Okay, so keep that in mind. We're going to look at the parts of a long bone because there are a few differences from a long bone versus the other group of bones. So long bones are, again, typically you think of your archetypal bone, the arm bone, the leg bone. We're going to see what's called the shaft of the bone. I'll come back to that in just a second, that slide. Sometimes it's easier to describe it. It's always easier for me to describe this stuff when there is a visual. So we have the shaft of a long bone. We call that the diaphysis. And the diaphysis of a long bone is going to have something called a medullary cavity. And that medullary cavity is not found in any other bone type. So we only see this medullary cavity being prevalent in the diaphysis or the shaft of a long bone. And we'll come back to some of that in a second. The other two aspects of a long bone are going to be the ends of the bone. The ends of the bone are called the epiphyses. One is an epiphysis. Here's a more med term kind of stuff. Singular is is at the end. Plural is going to be an es at the end. One is an epiphysis. Multiples are epiphyses. So we do have what's called a proximal epiphysis and a distal epiphysis of a long bone. And again, proximal just means we're closer to the attachment up at the shoulders. Distal means we're further away from that attachment site. So of the torso. Or down at the hip area. So anyway, the epiphysis is going to be the proximal epiphysis is going to be at the proximal end of the bone. This is the articulation spot, or where a joint forms with the neighboring bone. So we do see what's called articular cartilage on the ends of the bone. So at the epiphysis, we're going to see a covering of articular cartilage. And again, it's in blue, so that implies typically that there's no blood supply. So that's going to be avascular cartilage there. Now, the other thing, so anyhow, let's look at, so we have a distal epiphysis down here and a proximal epiphysis up here. That's why we went through proximal, not why, this is one of the many reasons why, but here's a really fine example of why it's great and helpful to know and understand the difference between proximal and distal. So when we start discussing the proximal end of this bone or the distal end of that bone, we're not having to reinvent the wheel. Right away, if we say proximal end of a bone, we're talking about a long bone. So just that fact alone, we generally remember only see proximal and distal on arms and legs, which happen to be long bones. So keep that in mind as well if you're faced with some of these multiple choice questions and something like that comes up. I think that again, if you see the proximal end of a bone or the proximal epiphysis of a bone would be found on an example of which of the following bone types: long bone, short bone, flat bone, irregular bone, sesamoid bone. You're not given a lot of info, but just the fact this is proximal epiphysis, that's enough to tell me that just the word proximal being in there, that I'm dealing with a long bone. So anyway, that's what's going on there. Again, we see the periosteum, and then we also see that compact bone layer. And notice too, the compact bone does come all the way up. This is an illustration, by the way, letter A. Letter B over here is an actual image of a bone. So anyway, you can see the compact bone is more dense. And then on the inside, we have that spongy bone or trabecular bone. And then one other item we see too is this medullary cavity is lined with something called endosteum. Remember, endo or end means inside of, like entry. So inside of the bone, endosteum. So we've got just like we had peri, meaning around the bone, periosteum, we have endo endosteum on the inside, kind of lining that inner area. And then finally, we do see that medullary cavity having something called bone marrow. This particular illustration shows that we're dealing with yellow bone marrow. Two things that tell me this illustration on the left is a fully grown individual's leg. This is a tibia this is a shin bone. And a couple of indicators that show me that this is a fully grown individual is, first off, the presence of yellow marrow. And second off, I have what's called an epiphyseal line that is solid right in through here. And we'll talk about that in a little bit. That's the growth, what a remnant of your growth plate. Okay, so let's stay on the yellow marrow for just a second. Yellow marrow becomes red, or yellow marrow is red bone marrow in newborns all the way up until probably around our late teens, early 20s. Once we're done growing really in length or in height, we're going to see the red marrow convert to being yellow marrow. And yellow, remember, in our anatomy coloring, yellow is an indicator of fat or adipose or something to do with fat. So we could assume, yep, growth plates. Yep, that's, we'll talk about that shortly. Yep, but see, that's an epiphyseal line. That's not an epiphyseal plate. This is the remnant of your growth plate, what we call an epiphyseal disc. So all of us are going to have this solid bony line or remnant of a growth plate. So yeah, I spend about 10 minutes on that here in just a few minutes. So stay tuned. For now, the yellow marrow is going to relate to being fat. Adults have yellow marrow in the medullary cavity. How about the spongy bone area, not just of the epiphyseal regions, but in other bone, all of the other ones, flat, irregular, short, those are going to have, remember, spongy bone as the primary makeup of the center of those bones. So that's where we're going to find what's called red marrow. Remember, one of the last function of bone on our list was hematopoiesis, and that simply means blood cell production. So blood cell production takes place in red marrow, and red marrow is found throughout our lives in spongy bone. So red blood cells only live about 120 days. So, and they're obviously important for delivery of oxygen, right? We need red blood cells. Without red blood cells, oxygen doesn't get delivered, and the mitochondria need that oxygen. So the point is, red blood cells work very hard, and they're only around for about 4 months. And you have about 20 million red blood cells just, in the tip of your finger. So you've got trillions of red blood cells constantly circulating through the body at all times. And some of the old ones, they go to the liver to die. They get plucked off the assembly line and basically recycled. We recycle some of the protein from the hemoglobin. We convert some of it to a bilirubin pigment. So where do we get new blood cells? They come from red bone marrow. All right. Well, remember this too about red marrow is that from 0 to 20 or so, 0 until you're done growing, red marrow is going to be found throughout the body, in the bone, including the medullary cavities. Once we reach adulthood or we're done growing, that red marrow of the medullary cavities and long bones converts to yellow marrow. So keep that in mind forever. The NCLEX asks that question every time. For whatever reason, that's something that you really need to know. Yellow marrow can convert back into red marrow in an adult under extreme conditions. Typically, we'd see that occur with chemotherapy, radiation, something extreme. Extreme stress would maybe cause yellow to convert back to being red. And again, why would it convert to being red? Because you need more red blood cells than you already have, because maybe you need more oxygen carriers. All right. So anyhow, that's what's going on there. Right. Yeah. Blood loss. Perfect. Perfect example. Yep. Absolutely, Stephanie. Yeah, blood loss. If you've got some, you've got an extreme situation of blood loss. That yellow marrow can convert. Yep. Oh, we do bone marrow transplants. We need them. Some folks need them. Um, they don't remember bone marrow is everywhere throughout our lives, except in the long bone medullary canal. When I take bone marrow from a donor, I'm going to go in. I don't go into the marrow cavity, right? I'm not going to take bone marrow from here because it's red. It's not red. I need red marrow for starters with a bone marrow transplant. I'm also probably not going to go after the epiphyseal region of a long bone. Like, for instance, like the shoulder. If I was going to go after the proximal epiphysis, spongy bone of the humerus or of the femur, there's a lot of muscle I'd have to get through to get there. So what we do is oftentimes we go in through the sternum. The sternum is a flat bone. There isn't a lot of muscle on top of the sternum. There's basically some skin and a little bit of adipose or subcutaneous fat, and then some fascia and connective tissue. Pretty less tissue damage to go into the sternum to draw out um, red bone marrow. We can also get it from the hip bone. That's another spot they like to go toward the back, the posterior area of the hip bone. They call it the PSIS, posterior superior iliac spine. It's where your hip bone kind of curves toward you can feel it in the front. There's like a point in the front. That's the front of the hip bone. If you find that curve and take it all the way to the back, you can feel kind of a bump back in there. So anyway, that part of the ilium has a lot of spongy bone, and it's fairly easy to access. So we also can take red marrow from there. But yeah, we're not going to go after your yellow marrow. We want the red marrow. You can see on this, you can barely see it. The epiphyseal line up here, it's almost non-visible. You might have a better chance of seeing it down here. You can kind of see this right here. You can see it on the superficial surface. This line right here. Okay. When we're growing, that's not there. That's going to be cartilage in between there called an epiphyseal disc. So we'll see that shortly. I mentioned all of that. We'll keep her moving. All right. So flat bone. Uh, flat bone, sesamoid, irregular, all have short bone. They all look like this. So this slide could say parts of any other bone than a long bone. So let's put it that way. It says flat bone just because I pulled up a flat bone on here. But again, this could be any other bone except a long bone. We just looked at long bone. So the difference between a long bone and all the other ones is the presence of the medullary cavity. Okay, so we still have periosteum. We still have compact bone. Then we have spongy bone making up the bulk of the flat or irregular, the non-long bones. And then we have more compact bone and then more periosteum. So it's basically just this kind of like a layered sandwich where you've got the buns, the periosteum buns, and then maybe a piece of cheese for the compact bone on the top bun and the bottom bun, and then a burger right in between, making up your spongy bone. So again, this is where we see a red marrow all the time. And again, a 120-day lifespan of red blood cells is not very long, so we need a perpetual pumping of blood cells throughout our time here. So the other thing real quick that I want to show you, we're looking at the skull. We've removed kind of the skull cap, and what we're looking at is the frontal bone, probably right about here. And we look at over here as an actual image of the frontal. We see a couple holes here. Those are normal. Those are not part of the spongy bone per se. Those are going to be the sinuses. Those are frontal sinuses. We saw that pseudostratified epithelium last week that lines the sinuses and other areas of the respiratory tract. Bone is a tissue. Hold on, somebody. Awesome. You too, Alyssa. Thanks for coming in, and have a great night. And the videos will be up sometime later this evening, I'm sure. Okay, so connective tissue. So what type of tissue is bone? Is it epithelial? Is it a lining or a covering? No. Is it muscular tissue? No, that's not a muscle. Is it nervous tissue? Nope. It doesn't fit any of those three categories. So that leaves us with connective tissue, cells in a matrix. So bone is a connective tissue. The extracellular portion, so we're talking about the matrix here, outside of the cells is going to be hardened and calcified, and that rigidity or that calcification is what provides all of that supportive and protective features. Plus, it gives us a lot of strength to the bone. What's in the matrix? Well, generally we're going to see we know the matrix is hardened and calcified, so we could probably assume calcium is in the matrix. That's a pretty safe assumption. And there's something called phosphate. We've seen that before. That's also going to be found in the matrix. And then I said a little bit ago, we might find some fluoride, right, or magnesium, and certainly sodium and sulfate. Hydroxyapatite, you'll probably never see that again. I don't think that's something that is that particularly pressing for you to etch into your long-term memories. However, I think calcium and phosphate being a couple of the primary inorganic salts contained in the matrix of bone, that would be good to know. And isn't a stretch. I think calcium you already know, phosphate you maybe already knew, and those other ones you certainly could relate to as well. The organic aspect of the matrix. So what's the difference? Remember, inorganic versus organic. This goes all the way back to Unit 2, chemistry. It's been a long time, but remember, organic means that there's carbon-hydrogen bonds or carbon-carbon bonds. It also typically means we're dealing with macromolecules of some sort or combos of macromolecules. So typically we would see organic molecules being proteins or carbohydrates or lipids, right? So what else are we going to find in the matrix besides that calcium and phosphate aspect? We're going to find something called ground substance. It's kind of like a thick, dense, not very movable. It's amorphous, so that means it doesn't really change or move around. Kind of like a glue. It's basically like cement. It's like cement glue, called ground substance, and it's going to have collagen. So there's your organic matter, right? Collagen is a protein, And then it's going to have what are called polysaccharides. And we know that term as well, right? Saccharides dealing with sugars. And if it says poly, it means many. So a polysaccharide is a long chain sugar or starchy type material. What good would that do inside the matrix of bone? Well, I think you kind of gave it away. It provides a stickum, kind of an adhesive quality to these inorganic salts and these collagenous fibers. So it basically is kind of like a sticky glue, right? Sugars can be real sticky, so that's why you'd see that polysaccharide in there. So that's the matrix. What about the cells? We've got three different bone cell types. We've got, we'll jump to the bottom one. We have what are called osteocytes. Those are the mature bone cells. I think we might have mentioned those guys last week when we talked a little bit about bone tissue. But osteocytes are mature bone cells. Cyte means cells, right? And osteo means bone. The other two, blasts, are the builders. These are generally thought of as being more immature bone cells. They're probably the youngest of the group. They also have the most energy, and they like to build a lot. So these guys are the tiny little bone builders. Okay, so they help with depositing calcium and phosphate. Blasts build bone. Class, they're the kind of the masters, if you will, of the sculpting of the bone. So the class are going to chisel bone. So sometimes the blasts get a little overzealous, and the class come in right behind them and kind of smooth out the rough edges. So under stress, right, going back to bone spurs, osteoblasts are going to outdo osteoclasts. Okay, so osteoblast activity is more prevalent than osteoclast activity. That's what leads to bone spurs. Okay, when blasts are out of control, the class can't keep up, the chiselers can't keep up. That's when spurs form. Okay, so class are a little bigger. They're a little more advanced in what they're doing. They need a little more energy, so we'd see a lot more mitochondria with the osteoclast because again they're a little busier. It's easier to mold and or to throw a bunch of clay together. It's not so easy. It takes a lot more energy to come in and kind of mold and smooth everything out. And that's what the class do. The blasts just throw all the materials down. The class come in and actually do a lot of the more refined work. And then a cyte is the mature bone cell, and we see osteocytes live in a little cocoon called a lacuna. Okay, so the cocoon for an osteocyte is called a lacuna. Okay. With an E on the end, they're called lacunae, and that would be plural. So an A at the end is singular, an AE is plural, like a vertebra is one vertebra. Vertebrae are multiple vertebrae. So that's what's going on here. So we have two lacunae, two osteocytes. You notice we also have some sort of connection between osteocytes. We're going to see these little canals called canaliculi, and these are little processes, cytoplasmic processes. So we do have a connection and a link. We we see these osteocytes sharing calcium, phosphorus, glucose, whatever is needed. They can communicate with one another. It's highly vascularized. Bone is, and again, this is compact bone, highly vascularized, a lot of blood. So we have what are called osteons. Osteons, you'll be asked, I'm sure, what is the smallest structural unit of bone? And the smallest structural unit of bone is called an osteon. Okay, and an osteon is a cylinder, kind of like tree rings. So here we've got, or almost like a tree. Okay, so an osteon is like a tree. And we can see that tree has multiple layers. Okay, and then we can see also, notice there's all kinds of little blackish purple spots in there. Remember from cells and tissues last week that blackish purple, dark violet implies that there's a nucleus involved, right? There's DNA that's getting stained. And so that's what we have going on here is we have the staining of all of these nuclei. So you can see these purples are indicative of individual osteocytes. And then you can also see their little tendrils kind of connecting. We've got little canals where blood vessels and blood supply and nutrients can get passed from cell to cell. And then we have the central canal right down the center of the osteon. Again, that's where we're going to see blood vessels. Okay, that's going to be vascularized. So another illustration that we see, this osteon here also has these concentric rings. Those are called lamellae. Okay. One is a lamella. Okay, so that's the concentric ring is a lamella. And then kind of in between rings is where we find the cocoons or the lacuna, where the osteocytes live. And again, these little canals that connect them and allow them to get nutrients in and groceries in, garbage out, right? And then we have this central canal or Haversian canal, where again, we can see blood vessels traveling up through that area to be able to drop off nutrients and gases and pick up wastes. And we see kind of so we see the north-south Haversian or central canal, and then we see more of a transverse canal they call a perforating canal or Volkmann's canal. Okay. And then finally, we do see spongy bone in there as well. So a couple new terms, right? Osteoblast, osteoclast, blast build, clast chisel. Osteocytes are mature bone cells. They kind of live in little cocoons we call lacunae. And then all of those lacunae are kind of encased in these concentric rings called lamellae. And we put all of that together and we get an osteon. Boy, if that doesn't sound like Star Trek or Star Wars, I don't know what does. Good Lord, this is a lot. You're telling me, Stephanie. Yeah, I know. Yeah, it's a lot. I'll tell you guys what, if out of this, what we've talked to up to this point, if you can remember, there's long bones, short bones, flat bones, irregular bones, sesamoids. Know those 5 bone types, and we'll see more examples of those as we go. Know the layers of a bone: periosteum, then compact bone, then spongy bone. Okay, know that. And then within the long bones, you have a medullary canal where bone marrow lives. Okay. And then once we look at the cellular aspects, we see blasts building bone and clasts chiseling bone and sites as mature bone cells. If this stuff here, this is getting really into some microanatomy, right? So take it for what it's worth. But if you can remember all of that other stuff and keep working off of that as your foundation, you'll be just fine. If you never remember what a lacuna is, just remember cocoon, lacuna. It's the little cocoon that the osteocytes live in, okay, or the little cave. Okay, lamellae is just think of layers, lamellayers. Okay, lamella means layers. So that's a lot, I know, but it takes a lot of time and stuff. Lori, you're looking a little bit glazed over. Yep. See you too, Stephanie. Everybody else, I noticed they don't show themselves. They're too chicken. I don't even know if they're there. So that's okay. I don't blame them. Ah, so anyhow, well, what time is it? Right, so that's the other thing. It could be 10:30 by now. The election's probably already happened. Do we have the results in yet? Oh, it's still good. It's 7:30. We've been going at it an hour and a half straight, believe it or not. Well, let's go at it just a little longer. Again, you guys, I don't want to I don't want to muddy the waters anymore than I already have. Oh, there's one term here. So that's compact bone. Spongy bone, there's one term you want to relate with spongy bone, other than the one we already saw, cancellous, spongy, and then this term here, trabeculae. So just add that as in with kind of your synonyms or your groupings of like terms. Cancellous bone, spongy bone, trabeculae. They all go to the trabeculae are kind of like the plates that make it up. But again, it's A and P, especially the A part of A and P, is a lot of kind of like word association. So associate compact bone, osteoblast, osteoclast, chiseler, builders and chiselers. Okay, and then spongy bone or cancellous bone is these trabeculae. And again, this is all new for most of you, so it's totally understandable. That's why we do spend quite a bit of time on it. We do see it just we inundate you with it. Blood supply, again, I'm not concerned. If you saw osteon, you want to think it's like a bone, functional unit of bone, right? Osteon, Haversian, and these are blood supply networks. Just remember, blood and bone go well together. Red blood cells are produced in bone. We need to get nutrients to the cells that are producing the red blood cells, these mast cells, or these, they call them hemopoietic stem cells. Okay, so that's all advanced A&P stuff, but we need to get blood to bone. We need to get blood away from bone. Highly vascularized. All right, marrow, we already talked about that. I'm not going to spend any more time on that. Cartilage, we've already talked about. You guys can go back into last week if you want to see more with cartilage. Remember, hyaline is the milk glass appearance. Elastic's going to have some elastic fibers, and fibrocartilage is going to have a lot more collagen fibers in the matrix. So we see a few examples of each of those as well. Hey, all right. Yum. So let's see. Yeah, I know I'm glazed over. This is like hour 6 probably of this talk. So it's, which again, I lose track of time because I could talk about this stuff all day, and I know it sounds like it's a lot of information, a lot of terminology, and which it is, and I certainly wouldn't expect you guys to pick it up right away, to pick it up today. But I would expect you to as you start diving further into Unit 5, some of this information is ringing around a little bit in your brains from being here, and then it'll translate into what you're seeing and doing. And then on Thursday, we're going to be neck deep again with visible body this time. So let's keep her moving. Endochondrial, we see this word, it looks like a lot. So again, a lot of terminology, we have to be able to break it down. So we see chondro means cartilage, endo means inside. So inside the cartilage, bone forms. So you may not have known this, maybe you do. But your skeleton when you're in the womb is primarily cartilage. Okay, so a fetal skeleton is primarily cartilage, and it's encased in kind of like a perichondrium, just like we had the periosteum around the bone. We have perichondrium around a little cartilaginous blob here. So we're in the womb, and we're a little embryo and then a fetus. And as we go along, as in their fetal stage, we start to see some blood flow going into and out of bone. So that's a good thing. What that means is maybe we're starting to get ready to wake these chondrocytes up, and maybe think about starting to get some osteoblast activity going, and maybe start to think about calcifying things a little bit, hardening things up. We can't let it happen, of course, overnight. This has got to be a slow process as part of the fetal developments that occurs over those last probably, oh, I don't know, 20, but basically the last two trimesters. So about 30 or so weeks, 28 weeks is spent slowly doing what we're showing here. Right? Because baby's getting bigger. Hey, you go get your ultrasound, they measure the skull, they measure some other things, and they see that the baby's growing. So we are seeing these little cartilaginous blobs certainly are growing, but at the same time, we're also starting to see more vascularization going on. We're starting to see then the blast we're starting to see the blast build and convert the cartilage, calcify that cartilage, the class start chiseling away, kind of a hollow medullary cavity there. This is now what we call the primary ossification center. Ossification simply means the process of building bone. Okay. Primary ossification center is going to be found in the diaphysis. Okay, the diaphysis. And then as we move a little bit further, we're getting a little bit older. We're still in the womb, but we're getting closer to running out of time and space. So the bone's going to keep growing, and the cartilage is getting more and more cartilage becomes ossified. And then we start to see this happen. We start to see what we call a secondary ossification center forming. So that's going to be again at the epiphysis, or at the end of the bone. And again, the bone just keeps growing in length and growing in length. And at this point here, we're probably out of the womb by now. So we're going to see, the newborn and those first the infancy stages, and then as we get to being toddlers and into pre-K, things start to look more like this. So we kind of go from this to maybe something more like this. And then, as we get to be closer to, 18, 19, 20 years old, this epiphyseal plate or disc, it starts to become completely calcified. And now we can't really tell the difference much between the secondary ossification center and the primary ossification center. So that's what's going on with bone growth. And again, this is going on pre-birth while we're in the womb, and it really ceases. It's different for everybody, right? Some people stop growing at like 13, 14, 15. Some people stop in their early mid 20s. So everybody is slightly different. Yep, absolutely right. Yep. Stay the course. Just keep plugging away. It does. And again, you're this foundational information that you're getting and exposing yourself to, and will continue to in advanced and in all of the classes you take. They're all linked together. Your foundation for once you're ready to take the NCLEX, once you're at that those job interviews, and you're on your first day of work, or maybe some of you already work in healthcare and you're just moving further in it. But either way, all of this information is extremely applicable, and you're going to see it just all meshing together into, instead of this big ball of tangled messy yarn, we're just pulling that string and that yarn, and we're basically crocheting a beautiful scarf or sweater or whatever tapestry. So we're taking that wound up ball of crazy yarn that doesn't look like it could possibly be anything but a big giant mess, and we're going to turn it into a tapestry that you can actually see everything on it. But to get from that ball of yarn to that tapestry takes a lot of effort. It takes a lot of crocheting. And I don't know about you, but I can't crochet. I can't thread a needle. Not that you thread needles for crochet, but I know it's hooks, and it's a lot of this and this and this, and this, but you can turn this ball of crazy into something, or a skein, I guess, to a skein of crazy into something just immaculately layered and beautiful. And you are the one, each and every one of you who did that crocheting, who did that work to get that tapestry to look like it does. And every one of you have the same skein of anatomy yarn. Okay. Now, how you're going to make that anatomy yarn into something beautiful, that's where I come in. I help you kind of unwind that yarn, and get that hook going, and get every single loop in the right spot, get each and every of your lines counted just right. And then we'll maybe start adding some other color to that. Well, some yarn, right, it's not just one color, right? The anatomy yarn is that kind of multicolored yarn that you see when you're at Walmart in the yarn aisle. I'm sure all of you shop at the yarn aisle. I do, not because like I say, I don't crochet, but my wife is amazing. She could whip something up in 5 minutes. She could take a skein of yarn and make a stocking hat or a scarf in a few hours. It's pretty mind blowing. But that's where all that stuff comes in. That's what you have, you guys. You have just a big blob of yarn, and I don't know how to crochet. Well, that's what I'm here to do. I'm helping you crochet. I'm helping you see that yarn for more than just a ball. And as you're piecing it all together, you're going to see something at the end that's going to be monumental in your careers, in your livelihoods, and in your personal lives as well. So keep that in mind, and don't view any of the work that you're doing in here, and most of you don't, maybe none of you do, I hope you don't, I don't view any of what we do as punitive, as a punishment. I hope you don't, or as busy work. This is the real deal. This is medical. This is the life you're going to lead. So I'm glad you're here. All right. So anyway, you could see x-rays, toddler, school age, and young adolescent. You could see all of that space in there between the bones, and you see they're kind of separate, and then we start to get them a little more closed up. You can really see it's dramatic down here with the radius. You can barely even tell there's a radius over here, and then all of a sudden a radius pops up, and then we've got this little bump here. So here's the radius, and we got a chunk of it there, and then we come over here, they're a little older. Now we've got this even bigger chunk of the radius. It's starting to become a little bit more of a cohesive bone. You see the ulna doing the same thing. And again, we still see these are not completely sealed up yet. There's still some space in there. So we do know that they're not done growing. Anyway, epiphyseal plate, bone remodeling. Okay. So that's the long and the short of it. Lastly, I think almost lastly, fracture, at least with this chapter 6, fracture healing. Again, bone is highly vascularized. So if we get a break in a bone, there's going to be a lot of blood. So the first thing we need to do is stop the bleeding. So we're going to develop kind of a hematoma, or a blood clot, basically. And then after a couple weeks, we're going to start developing what they call a soft procallus. And a procallus basically means a precursor. It means like I'm in favor of a callus, right? I'm pro-callus. I'm in favor of a callus. So that's what's going on here. And then after so osteoblast activity through the roof, and then we start to get that bony callus, and then osteoclast activity, kind of piggybacking, and then eventually we're going to have some basically a kind of a hemolysis, or kind of like a clotting dissolving mechanism is going to come in, or chemicals. We have some specialized chemicals that dissolve clots. So that'll do that, and then we're left with this nice, even probably thicker and stronger. You can break. There's a myth that you can't break the same bone twice. That's not true. You can break the same bone multiple times. You probably won't break the bone in the exact same spot, though. I think maybe that's where the that comes in, and is that the odds of a break happening exactly right along the same spot are extremely slim. But I could break it here, or I could break it here. Anyway, that's by the way, remember, stress on bone builds bone. So if I do have a fracture, depending on the degree of and type of fracture, we'll talk about fracture types a little bit more on Thursday. But depending on the type of fracture, we may be able to simply put you in a brace as opposed to putting that, that hard plaster cast. We're going to mobilize your musculature and your joints for 8, 10, 12 weeks, and then everything's going to be fine. Well, sometimes, but that's going to atrophy muscle. It's going to keep the process kind of slowed down of bone healing. So right now we're starting to work a lot more. Not right. This has been going on for quite a while, probably 15, 20 years. We've been experimenting and now moving more into bracing and splinting for fractures, and then getting folks to start doing some physical therapy almost right after the fracture has occurred. Within 48 to 72 hours, we have the individual starting to do stuff, because stress, because we're a little stress on the bone is going to get this week 4 to 16, potentially closer into week 2, where we're going to see that process speed up. So depending on the type of break and the severity, we can potentially see a lot faster healing with physical therapy involved earlier in the process of a fracture, as opposed to at the end of the process. Yep, absolutely. Amen. Yep. We are all multi-dimensional pegs that don't need to fit in any round, square, or multi-dimensional holes, right? We're all beauty. The beauty of life is, and we hear the words diversity a lot, right? Like how important it is to understand and embrace diversity, which it is, right? Because we all we come from so many different backgrounds, on every level, right? Socioeconomics, religious, cultural, spiritual. I mean, it's endless, right? Right down to maybe whether you're a Coke person or a Pepsi person. I mean, yeah, like but anyway, there's so many Domino's or Little Caesars. That's for you, Craig. But or Pizza Hut. There's Walmart or Target. So anyway, we could argue about anything, right? I mean, because we have so many differences, but diversity is extremely important to embrace it, to understand it. But it's also just as important to understand and embrace sameness too, right? I know that may seem like a mind screw and counterintuitive, but especially you guys taking A&P, the degree of same, and if we could really embrace sameness as much as we embrace diversity, problem solved, right? Who the hell's arguing about anything? We're the same, yet we're extremely diverse in our sameness, right? And we're all human. I think. I don't know. Even that may be debatable. I don't, this day and age. Who knows, right? Uh, Beam me up, Scotty. All right. So anyway, we're all here for a variety of different reasons. All of our intentions are different, but I think ultimately we all have the same general goals, and that is to be happy and healthy and balanced and you know avoiding confrontations and conflicts, and embracing discussions, and really just having an open mind, being pragmatic and objective, and not falling for traps, because a lot of times it's some people are provocateurs, and they want to bait you into feeling deficient or feeling weak, or yeah. Don't fall for that. You guys are stronger. So you're the strongest individuals that you could ever imagine. You're all very strong and powerful in your own rights. Yeah. You're making it through this class. That's enough said, right? Um, so, and you're going to be working in healthcare. I mean, if there isn't any profession that requires as much patience and compassion, and understanding of the human condition, and that every situation has its own merits and its own uh, uh, facts and factors that played a role, and not any one individual at any one time is potentially even that same way of thinking and behaving the next time you see them. So, as healthcare providers, we really have to keep that in mind, and judgment free zones, and not getting stuck into in negativity. I mean, the world has so much negativity as it is, and why fall for that trap? Your goal is to really to be positive and even neutral. I'm not here to tell everybody to walk around with a smile on your face and cheerlead everywhere you go. I'm not into that necessarily either. I don't need the constant, you pep pumping you up stuff. But I do, we all like positivity, but being neutral to positive really enables you to see a clear picture, and to hear the clear sounds, and to feel clarity all around you, to be able to have discernment. And that's what's going to get you through life. That's the anti-aging. That's the health. That's what maintains homeostasis. Discernment, to being able to discern what's for me and what isn't. It's that dualistic and simple. And there are certain things that may seem a little sketchy. It's probably because it is. So, you know, listen to that sixth sense. We don't teach that in A&P. They don't have that in our, when we go through the nervous system and the sensory stuff. We don't have a little chapter on metaphysics where we talk about sensory, extrasensory, and suprasensory, and sixth senses, and gut intuition, and gut instincts, and stuff like that. But that is a real thing, and I think all of you can agree and with it, just based on your own experience alone. We don't have to run a bunch of science experiments and put it in the textbook for it to be necessarily real. So I think all of us have been in situations where we maybe felt something, and maybe listened and things turned out great, maybe didn't listen, things didn't turn out so great. Everything's a learning opportunity. So that's all that was, right? It's a learning opportunity every day and every moment of your lives. So anyway, the axial skeleton and the appendicular skeleton, we're going to go through in detail on Thursday. You guys have enough info in your brains. Several of you still have some work to do on Unit 4. So please, by all means, get her going, and let some of this sink in a little bit. And if you have a chance between now and our next meeting on Thursday, maybe take a peek at the portfolio assignments, maybe go in and look at the Padlets and watch a couple videos, and just kind of start getting your feet wet a little bit, because we do have a little bit of time with this. We have until October 13th, which seems like it's 2 weeks. So we'll do what we got to do, and take care of biz.